section, which is our hospital overlooking the spectacular Mediterranean Sea. And my work revolves around patients with backgrounds of proliferative lupus leukoplakia that go on to develop squamous cell carcinoma. And we all know that PVL is a distinctive form of leukoplakia with a very high molecular transformation rate of up to approximately 70%. So the aim of our study was first and foremost to retrospectively analyze and document the features of squamous cell carcinoma arising in patients with PVL, and to then compare these features with standard conventional squamous cell carcinoma to see whether these lesions should be designated as a separate clinical entity. Now, we selected the patients with PVL based on the diagnostic criteria that was set forth by Katsakis and by Bacon, which are multiple lesions that develop over time in multiple locations throughout the oral cavity, and that almost always will eventually progress into a squamous cell carcinoma. And they progress in stages, which have clinical and histopathological progressive changes. For example, this would be stage 1. It's a homogeneous white lesion, which mimics either a lichen planus, lichen reaction, or leukoplakia, and that's the histological picture of either lichen planus or lichen reaction. Often the patients will then return with a progressive type of lesion, an exophytic type of lesion, which we refer to as Bruch's hyperplasia. And you can see these long epithelial fronds, which is characteristic. In stage number 3, the patient will return, it could be over years, with a more progressive type of lesion, the Bruch's carcinoma. As you see here on the right, it's a typical histological picture of Bruch's carcinoma. And like I said, almost 70% or more will eventually return with a full-blown squamous cell carcinoma. Now, in our study, we had 15 patients with PVL, and of those 15 patients, there were 48 cases of squamous cell carcinoma. The location was primarily in the buccal mucosa, the gingiva and palate, and about 12% presented on the tongue and the floor of the mouth. Now, interestingly enough, the ones that were on the tongue, 2 out of 5 presented on the dorsal tongue, which is highly unlikely for squamous cell carcinoma. Now, based on this epidemiology, we chose cases of conventional squamous cell carcinoma only from the buccal mucosa, gingiva, and palate, of which there were 49 cases. Now, the average age of patients with PVL is quite similar with standard conventional squamous cell carcinoma. Now, unlike Silverman, who proposed that PVL presented predominantly in female patients, we did not find such a finding. What we did find was, like Hansen and Silverman, who noted that PVL patients were non-smokers, which was exactly what we found. Now, in our retrospective analysis, we looked at the histological features, the histological risk score proposed by Brandwein. We did an immunohistochemistry analysis of P53, Ki67, and P16 for HPV. We looked at the clinical stage. We looked at the marginal status at the time of surgery, and of course, the prognosis. Statistical analysis was done by the chi-square and the exact Fisher as needed to look at associations between the two groups. And survival analysis was done by the Kaplan-Meier, as well as looking at the short-term and the long-term survival differences, using both log rank and the Breswell test. Differences in tumor thickness was noted between PVL patients and conventional squamous cell carcinoma, and it was statistically significant. There was no difference in the histological grade. Now, Brandwein set up a proposal for a histological risk score, and she wanted to know the patients that were at highest risk based on histological factors, and she chose 3 parameters: perineural invasion, the worst pattern of invasion, and a lymphocytic post-response. And in our study, we noted that there were significant differences between the two groups, as patients with conventional squamous cell carcinoma had a higher histologic risk score. Now, we also looked at the clinical stage. The majority of patients with PVL-associated squamous cell carcinoma were diagnosed initially at low clinical stage, and that was significant. And it was based on a smaller tumor size. There were no cases of either lymph node metastases or distant metastases in any of the PBL patients that went on to develop squamous cell carcinoma. Regarding recurrence, each PBL patient, on average, had 3.2 recurrences of squamous cell carcinoma. And that's in comparison to only 12% of the patients who had a recurrence who had conventional squamous cell carcinoma. And this cannot be related to either negative margins at the time of surgery or whether the patient had or did not have adjuvant therapy such as chemotherapy or radiation. If we look at overall survival, what we found was that the short term, which we noted at 4 years, survival of PBL patients was 100%. And that was significant, as the patients with conventional squamous cell carcinoma only had a survival rate of 57% at 4 years. When you looked at the long-term survival, there were no significant differences. But to emphasize, patients with PBL who went on to develop squamous cell carcinoma had an average duration of illness of 70 months, as opposed to patients with conventional squamous cell carcinoma who survived only 7 months. Immunohistochemistry analysis did not find any differences between either Ki67 or P16 between the two groups. But what they did find was that P53 was significant, as patients with conventional squamous cell carcinoma tended to strongly express P53 more of the time. In conclusion, we still do not know what is the cause of PBL, although because of its multifocal nature, there are those that suggest that maybe there's a viral cause. But like those before me, we do not find any significant differences between the groups in the presence of HPV. And overall, in each group was approximately 20 to 25% of cases that had the presence of HPV. But what our study does show is that it seems to verify that the clinical, histologic, and the prognostic differences are significant between the two groups and may characterize PBL patients with squamous cell carcinoma as a separate clinical identity. For example, location. They present in locations that are historically not considered high risk for squamous cell carcinoma. You know the patients claim not to smoke. Histologically, they tend to be more superficial, they tend to be more exophytic, and they have a smaller or lower histologic risk score. They are presenting an initial diagnosis with better clinical stages. There are no cases in our series of lymph node or distant metastases. And this is unusual because in previous reports, squamous cell carcinoma that present on the buccal mucosa and gingiva have a 66% metastatic rate. And finally, they have a better short-term overall survival. And I find that interesting because patients with PBL who present with multiple cases of squamous cell carcinoma who undergo multiple treatments and undergo multiple resections survive better than patients with conventional squamous cell carcinoma. The take-home message is that our study seems to suggest that patients with PBL who develop squamous cell carcinoma may represent a distinctive form of oral cancer and a less aggressive variant. And of course, this information may have practical implications when on trying to decide on the appropriate treatment plan. Now, although it is speculative, it is our opinion that multiple treatments, multiple rounds of chemotherapy and radiation over an average time span of 6 years may contribute to the patient's exhaustion, wasting away, and ultimate demise. But it only further emphasizes the need to better understand patients with PBL who develop squamous cell carcinoma so that we can develop the treatment strategies that are appropriate in their cases. And this is the famous Rambam, who was a very ancient physician, who was years before his time, who said the physician should not treat the disease, but the patient who is suffering from it. And I thank you.